Good morning everyone. Myself Dr. Kanhaiya Agrawal, Scientific Secretary of GP Association Gorakhpur. Today we have gathered here as a regular part of our morning CMEs. The topic for today is precocious puberty. This topic is some kind of very special because all the general physicians and general doctors are not able to manage it and find it out in the right diagnosis. So today we have invited Dr. Kanhaiya Agrawal, DM Endocrinology, who is a specialized doctor in this field, and he will enlighten us about this topic. Thank you.
So I'll be discussing about physiology of puberty, then the precocious puberty, classification, etiology, algorithms and management. So what is puberty? The puberty is a Latin word which means the coming to the age of manhood. So puberty is a complex process which involves the maturation of the FPG axis, maturation of the sexual organs, development of the secondary sexual characteristics and its appearance, the growth acceleration, capacity to fertile and psychological changes. So, in the process in which the biological procedure in which the child becomes the adult, child becomes the fertile. So, this is the span of the FPG axis from entire time till death. So, you can see here from entire time also there is the activation of the FPG axis around 20 to 30 week of the gestation. Thereafter the delivery, there is at the end of delivery, there is decrease in the fetal LH and FSH, but after the more of the placenta, there is lack of in the fetal child also. So there is surge of the LH and FSH, that is activation of the FPG axis. This is called mini puberty. The role of mini puberty is to make germ cells more proliferate and mature, so that it can help in the future for the fertility. Later on, at 8 to 9 years, depending upon the male and female child, they develop activation of the FPG axis. So this is the just simplified manner of this FPG axis in male and female. The top panel is for the male child. The mini puberty is well explained in the male child. It can be seen up to from birth to 6 months. Later on, its FPG axis again deactivates, and in female child it is less explained, and it lasts up to the 3 years. Again, the FPG axis activates at the age of 8 to 9 years in both male and female. So from birth, the prepubertal phase, the dormant hypothalamic axis is there. There will be undetectable level of LH and FSH, and at 1 to 3 before the clinical of puberty, there is a gradual rise of the LH and FSH. So LH rises first, especially in the night, because the half-life of the LH is around 20 minutes. So it can be seen easily as a pulsatile manner. However, the FSH has a long half-life up to 4 hours. So the pulsatility of the FSH is not clearly seen. So this is the hormone story of the child from birth till death. So in utero again, similar to previous slide, this is for the wire testosterone. This is pink is for the estradiol. So there is again in utero the rise of the testosterone and FPG axis. In mini puberty similarly there is activation of the FPG axis and both T and T2 depending upon the gender. And again at 8 to 9 years there is activation of the FPG axis. So puberty physiology, how it occurs. Still after various studies, till my knowledge, there is no definite answer to this question that how the puberty occurs. However, there are many theories, but most accepted theory is the critical body fat and body weight which are required for the initiation of the puberty. This theory is supported by when we see the athletics, they are the highly competitive and highly, so they have low body fat, so they usually have the delayed puberty. However, those who are malnutrited, they also have the delayed menarche. Overweight girls usually have the early menarche, and the patient with anorexia nervosa revert to the prepubertal pattern of the gonadotropin secretions as the body weight decreases. So, how this the puberty begins? So, it usually begins from the activation of this HPG axis from hypothalamus. Hypothalamus has the various neuropeptides like kisspeptin, neurokinin, and dynorphin. This is related by the Candy neurons, K and D Y. So, this kisspeptin acts. This kisspeptin acts on the GnRH neurons in the pituitary and the GPR4 neurons in the pituitary glands and activates the gonadotropins. So this gonadotropin releasing hormones which act on the pituitary glands and start releasing the LH and FSH, which subsequently acts on the gonads and starts rising of the testosterone and estradiol occurs. These are the various genetic defects which occurs during the migration, during the synthesis of the gonadotropin releasing hormones, which is responsible for the development or activation of the HPG axis. So, like Calvin, we talk about the Calvin syndrome, FGFR1, again it's a part of same hypogonadisms, NELF, prokinetin 2 and its receptors, GPR4 receptor 54, that is receptor for the kisspeptin, and leptin gene and leptin receptor also responsible for the activation of the HPG axis. So, this is the how the rise of LH and FSH occurs. In the graph, we can see rise of LH usually seen in the first in the night. So first there is a, you can see here this phase is the REM phase of the first to 3 to 4 NREM phase, sorry. And there is a rise of the LH occurs mainly in this NREM deep sleep. Over a period of time, this possibility seen both in the night and daytime, but it usually starts from the night time. Similarly, in the boys also, the rise of LH usually occurs in the NREM or in the sleep phase. Later on, it occurs in both day and night time. So, the role of gonadotropins, what the role of FSH? So, FSH stimulates the gonadal cells of the ovary to produce the estrogen and it involves in the spermatogenesis in the testes. However, LH it stimulates the androstenedione synthesis in the theca cells, and this androstenedione goes in the gonadal cells in the ovary and responsible for the production of the estradiol under the influence of the FSH. And this LH again stimulates the testosterone in the male in the lady cells of the testes. So FSH is usually higher than LH in the pre-pubertal stages, and this reverses in the pubertal stage. In the pubertal stages, the LH is more as compared to FSH. So this is the feedback regulation of the ovarian function. The rise of GnRH leading to the release of LH and FSH, which act on the gonadal cells, leading the both synthesis of the estradiol by the transfer of androgens from theca cells to the gonadal cells. And this releases the inhibits the LH and FSH at the level of pituitary glands. And this is the axis in the male. Here and the both LH leads to the release of testosterone, which acts on both pituitary hypothalamus level and directly or either through conversion to the A2. However, the role of main inhibition by A2 only through the peripheral conversion, and also it is the inhibin which directly inhibits the FSH at the level of pituitary glands. So, in puberty, what are the characteristic features? So, Thilab and the breast bud appears in the first sign of the puberty and appearance of pubic hair 6 to 12 months later. Then, usually, interval of menarche after the development of the first symptom sign of puberty is around 2 years, and in between there is a growth spurt which occurs usually at stage 2 and 3. In the boys, the growth of testicular volume, like a prepubertal testicular volume, we say is 3 or less, but some says 4 also. So growth of testes is more than 3 ml in volume, followed by the pigmentation of the scrotum and growth of the penis, appearance of the pubic hair, followed by axillary hair, and growth spurts occur at stage 4 and 5. So we can, important thing is that the spurt is around 1 to 2 stages later in boys as compared to girls. So they have usually height difference of around 13 to 14 centimeter. So this is the staging of the female. As you can see, the pre-pubertal stage is here. There is no breast bud appearance. In stage 2, there is a breast bud appearance. In stage 3, there is both the enlargement of the nipple and breast tissues. In stage 4, there is secondary mouth appearance that after the elevation of the nipple. And in stage 5 is the full adult development of the breast. Similarly, in the pubic hair also, the pre-adolescent stage, in stage 1, the presence of slightly pigmented hair at the middle part of the labia, that is the stage 2, darkening of and curling of the hair and increase in amount is stage 3, and when it becomes coarse, curly and abundant but less than adult, not appearing in the middle part of the thigh, stage 4, when it appears in the middle of the thigh, stage 5. Similarly, for the boys, the pubertal stage from stage 1 to 5. In the stage 1, we can testicular enlargement, that is whichever period also. Stage 2 is the enlargement of scrotum and but it's pink and texture is altered. Stage 3 that's similarly texture with but enlarged size. Stage 4 is the darkening of the scrotum and stage 5 is the adult size. However, the pubic hair is similar to the development of the female. So, topic of this is precocious puberty. So, what is precocious puberty? So, appearance of the secondary sexual characteristic, that is thalak before age of 8 years in the female and stage before 9 years in the boys. So, we say it is precocious puberty. This definition is based on the Tanner study that was done in 1950s. So, that is around 2.5 mg below the mean. And similarly, I told that before 8 years in girls and 9 years in the boys. So in both sexes, premature adult occurs prior to the 8 years. Adult is usually the, like you can say that it's the biochemical diagnosis, and presence of DHEAs in the blood, we can say that is the adult. That occurs usually around 6 years. And menarche that is occurring before the age of 10 years is also defined as the precocious puberty. So the maturity occurs in 3 patterns. One is that the rapidly progressive. That means when the patient has the loss of height potential, when the development of precocious puberty occurs before the age of 6 years, we say that the disease is rapidly progressive. Or the development of one stage to another stage within 6 months, then we say it's the rapidly progressive disease. Slowly progressive is that when the parallel advances of the bone is occurred along with the linear growth, and the height potential is almost not disturbed when the development of disease is after the 6 years of age. And third stage is the spontaneous regressive or unsustained central precocious puberty. That we say that idiopathic, that is occurs at around 89 years. So epidemiology is that incidence is around 1 in 5,000 to 1 in 10,000, and it is more commonly seen in the female. The ratio is 3 to 5:1. And we can say by the cause, the most common cause is again the gonadotropin dependent precocious puberty, that is the GDPP. Around 70 to 80% of the chunk of precocious puberty is usually covered in GDPP. Again, 20 to 30% is GIPP. And again, the disease is predominant in female in either of the conditions. So in female, the most of the GDPP are idiopathic. However, if it is seen in the boy, the most of the disease is organic. Some of the tumor tissues may be present in the boy, which is central. And GIPP is almost, we can say that it is the organic or organ disease in the male in the central cases. So classification based on the primary site of hormonal production. So it is central, I told, it is the central or gonadotropin dependent or true precocious puberty. Another is the peripheral or gonadotropin independent precocious puberty, that is pseudo precocious puberty. Third is the mixed type. The precocious puberty can induce maturation of the hypothalamic axis, like we see in the patient of CAH or Macron-Albright syndrome, when the patient treat with the peripheral management, and after the withdrawal of such management, there is activation of the HPG axis. So that is the mixed type of the peripheral precocious puberty. So classification for the incomplete precocious puberty. Incomplete precocious puberty means any of the one of the feature of the precocious puberty sign are present, like thalak, dwarf, or menarche. So it can be premature thalarche only, it can be premature enarche also, it can be premature menarche also. So based on phenotypical features. So it can be asexual, like female have the development of precocious sign of its own characteristics, like breast and the menarche, and male has the testicular enlargement or the penile enlargement. Heterosexual, like when patient have the opposite sexual characteristics, like when there is clitoral enlargement in the female, and we see in the patient of Kanhaiya Agrawal, and the male has the development of the breast, as we see in the estrogen secreting tumors. So central precocious puberty is always the asexual, and peripheral precocious puberty can be asexual or heterosexual. So what are the causes of the central precocious puberty? So as I told that most of the cases are the idiopathic, And again, the CNS tumor like hematoma, cranioangioma, glioma, and pituitary adenoma. And various patients have the past history of the CNS infection, patient have the history of tuberculosis or meningitis, patient have any history of surgery or trauma or any history of cranial irradiation or any congenital malformation like cyst, hydrocephalus, and septicoptic dysplasia. So, talking about the causes of the peripheral precocious puberty, in the patient with isosexual in the female, various causes are there: macular white, ovarian cyst, tumors, and exogenous administration of the estrogens. And if the heterosexuality in the female, the patient usually have the congenital adrenal hyperplasia, patient usually have the higher amount of the androstenedione. And the testosterone secreting the adrenal tumors, sometimes some of the ovarian tumor also secretes the testosterone. In the boys, if it is the isosexual, then again the CH, the patient, various causes are there, it is a different topic. And the radial cell tumor, patient with the testotoxicosis, patient with the middle tumor in the patient with the Klinefelter syndrome, patient having the teratoma or glucocorticoid receptor defects or exogenous androgen administration. If they have the heterosexual in the boy, then again feminizing adrenocortical tumors, patient with the Peutz-Jeghers syndrome or exogenous administration of the estrogen. As I told, that can be combined peripheral and central precocious puberty, as you see in the CAH, macular white syndrome, and patient with the familial male precocity. It usually occurs in the late stage of the disease. So, how to approach when we suspect, how to confirm the precocious puberty, when to treat, how to treat, and what are the supporting care. So, these are some points which can be seen with the patient with the precocious puberty. If the patient has PIVA before the age of 8 years, if the patient has PIVA before the age of 8 years, if any of these two features is seen between 8 to 9 years, and most of the cases, then we have to ask for the history when they have the development of this characteristic before the 8 years or not. So if the growth velocity of such patient is more than 6 cm per year, it's very important. So as we see that in the patient pre-pubertal, we usually have the velocity of 4 to 5 cm per year. So patient usually has the height prognosis below the target height. In the rapid progression of the pubertal development, that means transition of one stage to another stage between the 6 months of duration. Clinical evidence of any neurogenic etiology and clinical evidence of any peripheral precocious puberty and menarche before the age of 10 years. All these are points are present, or any of these points are present, we can expect the precocity in the female. However, in the boys, the textual enlargement before the 9 years, PIVA before the 9 years, and similar to other in female, like velocity more than 6 cm per year, one stage to another stage within 6 months, and etiology and other evidence of the peripheral precocious puberty. These points are relating to the suspicion of the precocious puberty. So history taking is that when is the age of onset, that is date of birth, that is very important. In our setting, we used to say that patient family members or parents don't remember the date of birth. That is very important in diagnosing the or patient labeling the precocious puberty. Progression of symptoms, how to diabetic, order of symptoms. So very important that order of symptoms. Sometimes the order is not continuous, like not sequential order, like PIVA, PIVA, and the female. This usually has the PIVA, then menarche, then PIVA. Then like not sequential order. So it is mainly the peripheral precocious puberty. If it is sequential, PIVA, menarche, then we think for the central precocious puberty. Exposure to the hormones and medications. It is very important. Like some of the we have heard and not documented, but they say that the milk having the high amount of the estrogens and the cattle has been treated with estrogens. And this radiation exposure, like if the parents has been exposed with any radiation and child in contact with that, like in the patient with the radioactive treatment. Local pains like estrogen, neonatal or postnatal trauma, sinus injury, history of meningitis, encephalitis or hydrocephalus, developmental milestones, family history of early puberty, and history of any hypothyroidism or signs of hypothyroidism. So, based on this onset of the causes is also different. In family, if the child will have features of precocity, so macular white syndrome is seen in most of the cases. However, 18% of the cases can be idiopathic also. If the age of onset is 2 to 4 years, hematoma, I should think of it. That is the common age of hematoma. However, different cases can be idiopathic. And 3 to 5% patient have the CAH. However, when the age of pregnancy is 6 to 8 years, then most of the cases of the GPPP are the idiopathic. So examination, they have to look for the height, weight, calculation of the height velocity, if any patient have the any previously measured height or not. Staging of the breast, pubic hair, and any stage of menarche. And patient will be, what are the stages of the testicle volume? Testicle volume should be measured with the oculometer. Should not be the volume should not be measured with the sonologically. That is very important because the criteria has been given based on the oculometer only. So abdominal examination for any mass or ovarian cyst or tumor, and the logical examination for any deficit. So this is just example for the patient having the catholic and in the patient with the macular syndrome. Patient first should be done if it is suspected for central causes. For any serous tumor, you can call the papilledema or optic atrophy. And also we have to for the ambiguity in the female, in the male also, and other sign of the skin stigmata also to be looked for. This is a patient of macular syndrome having the catholic the buttocks, sometimes it will be not seen the sides, and the patient have the body deformity like Havertz dysplasia is seen in the proximal femurs. So this is the two features is filling, and patient have the precocity that is said to be gonadotropic independent precocious puberty. So what are the investigations? So whenever we have patient of precocious puberty, first go for the serum LH and E2 also. And if the LH are below the level or it is intermediate level, then you have to go for the generic stimulation test. That we do by the pictorial, we will be 100 microgram. Acute form is available here, Gorakhpur also. And we give subcutaneous and we use to measure the LH at 3 hours and E2 at 24 hours. So if the LH and FSH is not increasing, and we use the criteria for the LH only, then it is the gonadotropic independent precocious puberty. If the LH and FSH is increasing with this percent, then we say that it is GDPP. The cutoff for the LH is 80 micro IU per ml at the 24 hours after the stimulation. So if the basal LH are markedly elevated, definitely it is the gonadotropic dependent precocious puberty. So the cutoff, which is say the 0.3 micro IU per ml. So other investigations like we have to look for the E2 testosterone, we have to look for the thyroid function also before the evaluation of any cases of precocious puberty. The thyroid function is must. And radiographic assessment is very important to look for the bone age, because how rapid we can tell the patient that patient is going to compromise its spinal line. So bone age is very important, and better to look the bone age with the bone expert. That is the application available in mobile, and that is very important. We can get bone age accurately with that. So other investigations like kidney function test, electrolyte. Electrolyte is very important when suspecting for the congenital adrenal hyperplasia and HDH and cortisol also. And you will see abdomen and pelvic for any intraabdominal mass, and testis is usually when suspecting for the radical tumor, because radical tumor are such a small tumor, sometimes it cannot be palpated. So if you are suspecting for the peripheral cause, then you have to go for the USC testis, look for antibodies. So what is the role of neuroimaging? So it is said that for boys, the most cases of the precocious puberty in the central cause is usually organic. So for all the boys in the central precocious puberty, go for the SC, varicella and brain. However, in all others, in the development of disease before 6 years, and it is GDPP, then look for the intracranial lesion. However, some authorities say that if the patient with the GDPP, rule out the central causes, even in the boys and girls. So this is the hematoma. We can see here that the patient at the level of pituitary gland, there is a child with the precocious puberty. The child has 4 years, stage 4 of the breast development, and less than E2 was the child in the range of GDPP. So this is the T1 image, and so in the isolated lesion, it is likely to be a hematoma as the location is for that. So the most important slide I can say that how to differentiate that it is a GDPP or GIP. So this slide, the GDPP, that is most important is clinical development of growth, because that will give the idea of the patient if we have the central cause. However, in the GIP it is discordant. Another thing is that bone age and the growth velocity can be advanced in both the conditions. The enrollment, the testicular volume enrollment to ball is very important in the GDPP. However, it can be seen in the GIP also, but may not be always. Some conditions like hypothyroid can have the enlargement of the testes, especially in the macular pride, especially with the femoral testotoxicosis can have the enlargement of the testicular volume. Another thing is that the stimulation test, the rise of LH and E2, that is again seen in the patient with the GDPP. However, that cannot be seen in the patient with the GIPP. However, the ovary volume more than 2.8 ml and uterine length of more than 3.5 centimeters, that is sensitive of the precocious puberty, both either it is independent or dependent. So we must ask our ultrasonologist to measure the volume of the ovary. Sometimes we get 2 dimension only, but it was for 3 dimension of the ovary to have the ovary volume. So this is the approach to the boy with the precocious puberty. So whenever the boy has development of secondary sexual characteristics before the age of 9 years, so we have to look for the enlargement of tissue volumes less than 3 ml. Then if it is LH and LH is less and testosterone is high, then it is the ratio of GIP that is equal to independent precocious puberty. Then if it is independent, then we have to go for the second introduction progesterone. That is hydrogen in the morning 8 am sample and you load the, if it is increased, then it is the congenital adrenal hyperplasia. Or the cutoff is the 10 nanogram per ml. If the pH is quite high, that means the value of sometimes they say that 700, 500 micron per year, then it is essential of adrenal tumors. And any look for the any exogenous androgen exposure for the independent cause. If the tissue volume is more than 3 ml, and after the patient may have the penile enlargement. So look for the symmetrical or asymmetrical. If it is the asymmetrical enlargement of the testes, then it is either can be seen with the patient with the congenital adrenal TART. TART is the testicular adrenal based tumors. Patient can have the ladies tumor, patient can have the vaginal tumor. If the enlargement of testes is symmetrical and LH and testosterone both is raised, then it can be GGP. If the LH is decreased and testosterone is high, then it can be seen in testosterosis. Patient can have the acidic secretory tumor, or patient can have the vaginal tumor. If both LH and testosterone is low, then definitely it can be a primary hypothyroidism. Because hypothyroidism, the TSH has the that is spillover effect over the FSH of the Sertoli cells, and that related to the development or enlargement of the testes. For the boy, for the girl with the precocious puberty, that will be with age development before the age of 8 years or menarche before the age of 9 years, then have to look for the thyroid concentration. So that is first stage, and when we excluded the hypothyroidism, then we have to look for the basal or either basal LH&A2 level, or if that is low or intermediate, then we have to look for the asymmetric form of the LH&A2 level. If the LH&A2 is raised, it is GDPP, we have to look for the imaging for plot and intracranial lesion. If the LH is low, less, and A2 is high, then it is GIP, look for the ovarian cyst tumor, ventral low, and exposure. If both is less, then it can be isolated premature therapy and premature therapy. The important thing is that therapy, the age of presentation is usually 3 to 4 years. So now talking about incomplete precocious puberty, the incomplete precocious puberty, that is the child presenting with only therapy. So the important thing is that transition condition, like when the child is transitioning from the 6 to 8 years or 5 years, then we say that it is usually the transition phase. So can have like the definition of the precocious puberty has been changed in various other countries like Africa. Africa, the definition is 7 years. The Japan, the definition is 6 years. So in that, as they have the good capitals, they found that the age of 6 and 7 years for the precocious puberty. So therapy can be seen at around first year of life. It can persist up to 3 to 5 years. It is not a progressive disease. And it's mostly idiopathic, and it can either emit spontaneously or very slowly progressive, or no other sign of puberty development. Growth rate is normal, estradiol is normal, and treatment is just assurance of the family members and regularly monitoring for the size of the enlarged organ and the growth velocity. The growth velocity is very important. The appearance of the sexual hair before the age of 8 years in girls or 9 years in boys without other evidence of maturation, we say the premature puberty. So it is a slowly progressive condition. It requires no therapy. Longitudinal observation suggests that 50% of the affected girls are at high risk for the hyperandrogenism, PCOD, and metabolic syndrome. So those patients who have the PCOD can have the puberty even at the earlier age. So when we have the patient with premature puberty, look for the bone age. If the bone age is significantly advanced by 2 Hg, then look for the 17 Hg, look for the CH, look for the DHES. In the such condition, the more than 150 micron per year, then look for the any neoplasm in the ovary or adrenal. And if the also look for the testosterone level, if more than 0.6 nanomolar per liter, that is equivalent to around 2.5 nanogram per ml. inhibit or damage the growth hormone secreting cells. So patient, but the inhibiting neurons for the GnRH will be lost. So patient will have the simple precocious puberty but not the high spurt. So in this condition, patient should be treated with the GnRH analogs along with the growth hormone treatment. So the treatment for the simple precocious puberty is the GnRH agonist. So this, as we are thinking that patient have the activation of axis while giving the agonist. So when this gives the agonist molecule, so it has some modifications and it is found to be more potent as a natural form. So it prolongs the receptor occupancy and it has the more potent and it desensitizes the GnRH receptor for the long term of time. So when we start treatment, patient may have the like a large in the first 1 to 2 months. So we have counseled every patient before starting this treatment that patient may have the hyperactivity, patient may have the enlargement of the breast after in 1 to 2 months, but later on it will decreases the size of breast. So it also decreasing the absolute release of the gonadotropics on the pituitary gland. So the disease is progressive central precocious puberty. The indication of treatment is that height is predicted in a height that has to be calculated in the application is that is less. Psychologically distressing to the child and parents. That is very important and the disease is rapid progressive. So when these conditions are present, we have to deal with the agonist. So treatment is the prepared before is present that we our seniors are using in various conditions. So that we should do those is given 0.3 to 0.5 milligram per kg per dose. That we usually give 3.75 milligram intramuscularly once a month. Then if the no response is there after 3 months, then we used to give after like doses increasing of frequency is reduced. Other condition like other treatment like medroxyprogesterone for the first 3 months to counter the possible stimulatory effect of the GnRH agonist, which I told earlier, and it acts by continuous stimulation of the pituitary gonadotropics, thereby desensitizing the receptor and decreasing the LS level. So effect of therapy, how long to treatment should continue? Cessation of puberty development and cessation of growth. So they said that up to 11 to 12 years, treatment has to be continued. Thereafter we have to stop the treatment. In the girls, the breast development can regress in those with average stage 2 to 3 development, while it remains unchanged in girls with stage 3 and 4 and 3 to 5, and even increases the slight because of progressive adipose deposition. However, there is no effect in the pubic hair development. So follow, so time period is 3 months. Every 3 months we have to follow, and we have to look how to follow. We have to look for the LH level both at basal line with like when we patient is coming for the next injection dose. So we have to take the patient for the LH. Then we have to give the injection. Again after 3 years, again after 3 hours, we have to look for the LH level. The LH level is less than 3.3 microIU per ml at 3 hours, then we see that patient is having a disease controlled state. We have to look for the sexual maturity rate at every visit. Growth velocity is very important, and hormone studies I have told that LH and T2 have to look at the baseline and 3 hours after the next dose. So when to discontinue, as I told that the age is 11 years, hormone age is 12.5 years, we have to stop the treatment. Menarche occurs after 12 to 18 months of the cessation of therapy. Surgical, when we have any surgical etiology, especially in the peripheral conditions, we have to remove those peripheral tumors. And for the hypothalama, surgery is very hazardous. That can be life-ending or can create the morbidity to the patient. So hypothalamic hematoma should not be touched in such conditions. So for the peripheral precocious puberty, treatment of the cause is possible, like the testosterone, the aromatase inhibitor, ketoconazole, if the patient inhibit the steroid synthesis, we have to give 20 mg thrice daily. Cyproterone acetate, spironolactone, hydroxyprogesterone. These are the treatments for the peripheral precocious puberty. Accelerated enarche, thelarche have an excellent prognosis and do not require treatment. So the important thing is that before we have to level the accelerated such conditions, we have to plot other possible conditions after the basal test and instrumental test. So some special scenarios like child presenting with the precocious puberty with delayed bone age, so hypothyroidism should always be ruled out first. And why hypothyroidism and the precocious puberty? Like in the girls having the primary breast enlargement and menstrual bleeding, the latter can even be seen in the minimal breast enlargement. And pelvic sonography in such condition have the multicystic ovaries. And boys, they have the visual enlargement with modest or no penile enlargement and no pubic hair development. The enlargement of sella, which is typically seen in the patient with the hypothyroidism, that can be seen in the simple lateral axis of the skull, that sella is enlarged. So the mechanism I told that specificity spillover, the more TRH level at the level of hypothalamus that can stimulate the GnRH and leading to the more FSH rise. Then FSH rise is led to the menarche and the breast development and chest floor or enlargement in the boys. The most important thing before treating any condition in the precocious puberty is psychosocial impact. So we have to look for the condition of the both parents and child. Child has a social environment. They feel that they are like adult in childhood. So we have to counsel the patient. The psychiatric manifestation what the child have, that patient may go into depression. Patient may have the increased risk of abuse also, and patient may have the disruptive behaviors. Patient may have the parental anxiety, for such family members. So this social impact should always be dealt, and patient we have to give the time to such patients before starting any treatment. So warning signs of the effect on emotional development. So poor grades, problem at school, loss of interest in daily activities, depression, children of puberty are taller and they're older and their peer groups, unrealistic expectations from the parents, teachers and others, the child may go on stress. They perceive the themselves as different, however this does not have an long-term effect, however they can do well in the psychosocial conditions. And the sexual maturity at any immature age make them vulnerable to the victims for sexual abuse. So how parents cope with the issue can also determine how successfully child will cope. So the most important thing before starting treatment that parents should be confident before starting treatment. The goal is to prevent the kids from dwelling on sexual development or developing a poor self-image or low self-esteem. Try not to focus the comments on appearance and instead of praise the achievements of the school or sports and child's participation in other activities. Things to remember is that kids with precocious can be treated, preserve their adult health potential as well as limit the emotional and social effects. So the take home message for today's topic is that extent of evaluation should increase with the decreasing age of presentation. Precocious puberty with delayed bone age, think of hypothyroidism. Pattern and sequence of puberty development along with the rapidity progression is helpful in differentiating the symptoms and peripheral cause and helpful in the management of such cases. And isolated pubertal manifestations like menarche, isolated or menarche should be regularly followed and often for the bone age. And psychosocial support is as important as follow-up in such conditions. So I have references from various textbooks which we use to study in our training in the DM. So from my HOD Dr. Nathali sir, from William textbook of endocrinology, books that is the Behudani, that is the from pediatric endocrinology good book. And female history again is a pretty kind of and from various other articles I have taken these slides. So give the child with positive puberty, love, support and